Society. And the topic that we are going to manage in this 1.5 hour webinar will be revision total hip arthroplasty. So it's my honor to present my co-moderator in this session, Professor Fares Haddad from UK. Good afternoon, Fares.
Good afternoon, Oliver. Hi, everybody. And I think we're looking forward to a great couple of hours.
And I would like to also introduce these fantastic speakers that we will have today with us. Hello to our president of the European Society from Greece. Hello, Eleftherios.
Hello, everybody. Thank you very much for the kind invitation.
Also, I would like to introduce you, Francesco Benazzo from Italy. Hello, Francesco.
Hello. Good evening to everyone. And again, thank you very much for the invitation.
And we are happy also to say welcome to our friend from France. Hello, Sebastien. Good afternoon.
Hello, everyone. Happy to be part of this great faculty.
Also, say hello to our European Society Secretary, Stanislav Bondarenko from Ukraine. Hello, Stanislav.
Good evening, everyone. Thank you very much for the invitation. Thank you.
In a few minutes, Matt Wilson from UK will also join us. I think we have a very interesting 1.5 hours in this fantastic afternoon or evening or morning, depending on where you are now. But it will be very enjoyable time talking about these topics. In the first part, during the first 45 minutes, we'll have very interesting lectures about aseptic, septic, and unstable topics in revision total hip replacement. We will follow with a very interesting case from Ukraine of this revision surgery, and also we'll have the participation of the speakers. And finally, an amazing crossfire between Francesco Benazzo and Matt Wilson about these two options in acetabular revision. So this webinar is for all our attendees here and in other parts of the world. So please send your questions and try to be interactive with us through the chat. So you can set the question and we will ask the speakers about the question. And you will also can vote when we present the case. When we have this crossfire to find the winner of the crossfire. So please be interactive with us and try to participate in our European Hip Society webinar. So I think we have to start, Fares, with the first session. So if you don't mind, my co-moderator. So I will start with the first speaker, Eleftherios Tsiridis, talking about this aseptic loosening in total hip arthroplasty. Eleftherios, the podium is yours.
Well, thank you very much, sharing. And the topic was, let me share. And here we are, and I hope that you can all see my scan. Can you see my screen? Is everything all right?
Perfect. Please go on.
Yeah, thank you very much for this very kind invitation. Thank you very much, both of you, for chairing this session, and very happy to see all the faculty. So I was given the task to talk to you about the reconstruction, the stem reconstruction, with significant bone defects in my conflicts. I'm not going to bother you too much about the Paprosky classification. Is the gold standard of classifying the femur, starting from type 1, moving on to type 4, where things are very difficult to reconstruct because there's only a bone shell rather than any substance in the femur. For the rest of it is actually quantitative classification of the isthmus, how much of the isthmus is there, so you can fit a kind of a prosthesis. Now, going to a revision procedure, someone may need to have, except from radiograph, some sort of extra screening, like, for example, a CT scan or a CT angiography, or probably combine it with a 3D reconstruction. That applies to both socket, maybe more about socket, less for the femur, but sometimes the destruction of the femur is significant, so it is worth probably exploring the vascular supply of the rest of the bone. Now moving on straight to my practice, I go through a posterior approach to do my revision procedures. I think that gives us better access to pelvis and the femur, and it is extensile because we will see in the lower down that you probably need to employ several techniques to extract the implant and to protect the bone. So several crucial decisions. Sometimes we may think that the implants can be removed easily. Don't fool yourself about it. You need to be extremely careful, and the extraction of an implant is a very careful process if you want to preserve the bone. Decision number 2, access to the implants. It is also an important task. Sometimes it's not difficult to get to the socket, or probably to actually get access to the top of the femur, in which case you need to contemplate a kind of a osteotomy of the femur. Decision number 3, removing a femoral component starts from the top, from the shoulder, and usually you need to take down the extra bone or the soft tissues. Don't just pull it off. It will probably not come off, and it may be necessary to split the femur to do so. Decision number 4, be aware of the cemented implants. If the cement bundle is good, then you don't need to get crazy about removing all the cement. You may be able to do cement in cement revision. We have proven the concept in the past, and it works well. Removing the distal cement plug is probably a little bit more challenging, although an extended trochanteric osteotomy may do the job, but sometimes you need to melt the bone, the cement, using these ultrasonic devices. Decision number 5, extended trochanteric osteotomy. When the bone is fragile, you need to protect it. Or if the stem is very well fixed, you need to open up the femur. Otherwise, you cannot do the job from the top. So the extended trochanteric osteotomy is a technique well established, and I use it very often now in my practice. And it's actually, I reduce the femur and then I go to the linear aspera at the back, and from the lateral aspect of it, go like you can see in this little video. This is a posterior approach, and you lift up the vas lateralis. The stem was out in this particular case. It was very loose, but we had to remove the cement, and you can see how the bone is split. The back is the posterior part of the bone, and you open it with a saw. You extend the osteotomy to the anterior aspect of it, you complete it, and here we are. And then, of course, you remove the debris and the implant, and you wrap it up again over a fundum stem, or in some cases, or even over the actual stem, and the cables will do the job around it. You make sure that the abductors as well are recovered to the greater trochanter. Now, there are some descriptions of some sort of windows. I don't do that. I think the limited window is not going to do the job. A combination of the ETO with a Trefine version technique, as you can see here, described by Daniel Berry many years ago. Useful, but you need to cut the stem in situ. Not a very easy job. You need a diamond split bar. This is one of my cases. The stem was broken, but it was extremely difficult to remove the distal part. I made a window without disrupting the whole circumference of the bone, and I managed to get it out. You need to make a calculation where to find the distal fragment, and then you open the window, you recover it, and then a straight Wagner would do the job. Now, in terms of reconstruction, we've got straightforward options. We have the modular distal tapered stems. You've got good diaphysis, or even if not, then you stick it down to a good host bone. If you've got diaphysis available, it's fine. The monoblock Wagner is the working horse of our revision procedures. The only difficulty with it is if it goes long, then it is straight. So you need to go to an anatomical version if available. However, the operation is relatively straightforward. You see me here doing this. It was a revision for a periprosthetic fracture, even more easy, because the fracture site helps. The removal is like a pre-existing ETO, let's say, and then it's straightforward. You put the stem down, you put actually a thick Wagner. You need to hammer it down hard, and then you wrap the rest of the bone around with cables, making sure that you reconstruct the abductors. Cement and cement revision is also a valuable technique. I mean, you can see here a case where I use this on one side, the other side I use a straight Wagner. You can employ either technique depending on your judgment on the quality of the cement or the availability of the implants. When things get to a kind of a complex situation like recurrent dislocation, loss of bone, infection involving too much of bone loss, then you need to move on to proximal femoral replacement. You can see an alval case here as well. You see how much of this alval I have removed, and the proximal femoral replacement will do the job. I like to cement the distal part in. Or if there is a significant destruction following several revisions before, again, you keep as much of the host bone you can do, and then a proximal femoral replacement will do the job. Circular wires are useful to protect the bone from hoop stresses. Some mistakes that can happen, undersizing the stem. This is an undersized revision. You can see the end up result. You need to probably go back again and do the job properly. Mistake number 2, if you put a straight Wagner, although you think things may go well, you see it turned up to my practice, a patient operated on a year ago. It's not very easy to take Wagner stems, although they're out. So I went to an extensive ETO, and you can see how vigorous the extraction of the stem was. So you can see the ETO, which is more than expected, is the only solution to take the Wagner out. Mistake number 3, stability. One of my cases, I turned my attention to the revision of the stem, although ignoring the socket, I had a dislocation. Then I turned to a freedom constraint type of socket because the abductors do not work well. Impaction grafting is going to be discussed later on, touching upon it from my experience from Exeter, where I was trained. There's plenty of literature that it works well, and there is a significant follow-up into 15 years, even for young individuals. The technique is, as you know, and some of the examples, you can see these examples over the years, both for the acetabular and the femoral side. It works well, including complex periprosthetic fractures, some of the literature involving myself. Before I go, it's an opportunity, if you visit the area and performing a femoral reconstruction, to repair the abductors. This is what I do. When the abductors are gone, I'll use the glute max, I use the TFL, put them together. These are parts of the operation I usually do, and you can see the actual outcome is an opportunity. If you can, it's a straightforward technique, and you may have this kind of result after all. Thank you very much for your kind attention.
Thank you, Eleftherios. So we will move to the next speaker, who will talk about these difficult revisions in unstable total hip replacement. So Sebastien Lustig from France will talk about that. Sebastien, the podium is yours.
Thank you very much, Oliver, for the kind invitation. I have a few things to disclose. I've done some work with Stryker and stuff regarding some implants I'm going to mention, and the main one is I'm French, and I'm not allowed to talk about hip without mentioning at least once dual mobility. So you will hear some about this in my lecture. So the problem is, how do you manage this situation when you try to, manage a tricky bony situation and you end up with a tricky unstable situation and eventually an intraprosthetic, dislocation. So you need to understand why this might occur. So we know that, as you said, this is a devastating situation. It's still frequent to have instability. It's the first cause of revision. In some parts of the world, the numbers can be up to 10, 15, 20%, regarding the literature. We know that the results of revision for instability are definitely not great. and that the cost related is very significant. So this is definitely a challenging situation. It's very important to understand why this might occur and the rationale about, unstable hip. And you have two main, situations: the one when you get impingement, and the one when you get translation instability. So the impingement is not only due to a malposition. We're going to see that you have several features to consider to understand why, there might be some impingement during surgery. So, of course, if you have a very major component malposition, just like in this situation with a completely retroverted cup, or a very, vertical cup in the other situation, you definitely understand why this hip is creating early impingement. But we know now that it's more complex, and that actually the functional positioning of the cup might vary depending on the hip spine situation. And we have some stuck sitting, standing, patients that are going to create some, early impingement when they're going to sit, we're going to stand, and you have to take that into consideration. So it's not only a 2D static analysis. And if you combine this with some pretty bad design implants, and we learned from that in the past with this, historical implant I'm showing here, creating some really bad egg-net ratio and early impingement due to the specific, design of the stem. So very important also to consider that when you consider revision. Of course, some of our patients are challenging us. They want to get excessive range of motion. It's hard to manage them. Sometimes with conventional hip might be a place for resurfacing. But also in some part of the world, this is, very important, just like here, this case from my friend, yes, Neeraj in Algeria, and he has to deal with this tricky situation as well. Also, we know that somehow, obesity is going to also create some more challenge, because we might create some, not bony impingement, but soft tissue impingement because of the size of the side. And that's also something to consider when you're going to decide which kind of implant to use. The other part of, the instability of the hip is the translation issue, when the jump distance is exceeded, and you have various reasons for that. The main one is obviously to choose the right femoral head size, and we know that the larger the head, the greater the jump distance, and that's, the reason why when you go for revision, you try to use the optimal size of head. And this is also sometimes, connected with also some soft tissue laxity, because you had some several surgeries, so the abductor muscles are not there anymore, or you have, congenital muscular weakness or neurological issue that are, adding to the, issue with the jump distance because of this muscular weakness. Sometimes it's not the muscles, it's the bone when you have such situation with the trochanteric non-union, just like here. And the first thing you're going to have is to fix the bone, before considering doing anything on the hip arthroplasty itself. And then sometimes there's no more bone. So you have complete segmental proximal femoral bone loss, so that's creating obvious abductor weakness, and you have to compensate for that. And that's also going to create some situation you have to deal both with soft tissues and also constraint of the cup. And in addition, if you wait long enough and you have polyethylene, where it's going to also create some, change in the center of rotation and adding to the, instability of the hip. So you have to control all of these features. So that's leading us to how do we treat this situation, or sometimes just how to prevent, this situation. And this is about dealing with cup, stems, constraints of the implant, soft tissues, and sometimes non-operative management. So I mentioned the femoral head size, and for one, particular diameter, we try to use the larger head, possible, to try to increase the jump distance. And knowing that, we know that dual mobility is probably the best large head option, because you're going to increase the range of motion because of the mobile inserts. You're going to delay the neck insert contact because of the mobile insert, and you're also going to increase the jump distance because you are using the larger diameter and you are maintaining the center of rotation of the hip. But you need to understand that every design of dual mobility implants are not the same, and when you're using modular dual mobility because you want to use additional screw for fixation, then you are jeopardizing somehow the concept of the dual mobility, and definitely you don't get all the benefit from the jump distance. So when you're dealing with a revision for instability, maybe it's not the best option, and maybe you should try to use different options, to use monoblock dual mobility to try to get the maximum jump distance for this specific situation. Whatever the design, you have multiple publications with strong evidence than when you go for revision, in particular for unstable hip, dual mobility constructs, are giving you reduced dislocation rates, decreased re-revision, decreased reoperation, and is a cost-effective strategy. So this is definitely a construct to consider when you go for a revision scenario. Different options, you can use, modular, as I mentioned, you can use cemented dual mobility with different construct. And in all these different situations, it's possible to combine, correction of the anatomy of the bone loss and the benefit of the dual mobility construct. So we published recently about 2,000 cases presented at the International Hip Society that compared to large femur head, dual mobility construct is always a winner in tricky situation. And this is also in line with this recent publication from Mustafa Citak team showing that, in complex case, dual mobility cup is providing excellent control for stability at 5 and 9 years. You can see the numbers here with a decreased, dislocation rates considering the very tricky situation. And this is in line with this publication from Nico Rena and Matt Abdel at Mayo Clinic, showing that, when you have revision scenario, dual mobility components are doing better than any other construct. And in re-revision, it's even better. So in both situations, should go for a dual mobility construct. Of course, this is not the full story. And you have also to consider the anatomy and how to restore the anatomy. That's where the combined version concept comes into play. And you have to also consider that. But it's not only about the stem. You have multiple publications showing that if you just rely on the Levinek safe zone, or if you just rely on correcting the version of the stem without considering the cup, you might, be in a non-optimal situation. And this is definitely not telling you the full story, supporting the concept of combined anteversion, cup plus stem. And that's where robotic probably in the future is going to be very helpful with the 3D planning and the capacity to use virtual range of motion to anticipate that and to recreate even more for revision scenario, the optimal combined version, both of the stem and of the cup. Then if it doesn't work, what are the other options? You have, of course, the constraint liner, which is going to, help you and compensate for the muscular weakness. But we know mostly from the US literature, there are some limits and limited survival, and that should not be the first option to consider. Then regarding the soft tissue, we know that some, approach might be conservative, helping you to get stability. And so for revision, you have also some options. We're using some fascial arthroplasty to try to stabilize the hip. This is not the first, option to consider, but this is interesting when you have tried everything and you want to restore some stability of the hip, doing some soft tissue plasty with autograft or sometimes synthetic graft if you don't have enough soft tissue. Finally, if you have tried everything, of course, you have the orthesis, the non-operative treatment, very cumbersome. It's not well tolerated by the patient, but they're going to help. But they're going to definitely limit the range of motion to try to avoid instability. So how do you make the decision? I would advise you to read this paper from a Japanese team regarding very comprehensive approach and how to deal with every specific situation. And if you want to look to the future, you have this very nice paper from Philippe Ernigou showing us how artificial intelligence tomorrow is going to help us to make the right decision regarding which implant to use in this unstable scenario. So take a message, how do you manage unstable hip in 2024? You need to understand why the hip is unstable. It's not all about the cup, but the cup is playing a very significant role. And I think dual mobility today is really helping us. Constraint liner are also useful in some very difficult situation. And don't forget about the soft tissue. Thank you very much for your attention.
Thank you so much, Sebastien. It will be a very interesting discussion later on. So let's move to the next speaker. That will be my co-moderator in this webinar, Fares Haddad from UK, that will talk about new information in septic revision. Fares?
Thanks, Oliver. And I'm sorry not to speak to the exact title you had on the webinar, but Mustafa Citak only withdrew at the very last minute. So this is one perspective on infection, which I think some of which is new, but not new of this year, new in terms of the evolution of where we've been going for the last decade towards what I call a patient-centered approach. What we didn't want to do is leave the audience without any septic presentation at all. So I hope this will be useful to some people on the call. My disclosures are always important to share, although I don't have any conflicts in the infection world. And actually, this is an area where I think conflicts have been very important over the last decade or decade and a half. So we need to completely bear that in mind. The other issue is I'm going to talk to you about some controversial strategies that defy what we've routinely been taught. So it's important to consider those in the context that I work in a setting where I have a big team around me for infection, including infectious disease specialists, specialist nurses, specialist anaesthetists, all of whom are used to looking after these things. And in the UK, just like France, we're beginning to work in networks so that these cases are centralized, so you see a big volume of them and can learn from what you do. Because I think there is a major issue. And one of the reasons why I was keen that we always discuss this topic on these important revision sessions, because this is the killer complication. When you get an infection, your life is wrecked. People have likened it to cancer, and I think that's a pretty good analogy in terms of morbidity and mortality. The patients really deteriorate, and quite frankly, whilst we congratulate ourselves if we can do some successful interventions to control the infection, function has not been our priority. So we coined this expression that even the winners are losers, which sadly is often true. So in reality, we need to define some algorithms for when to do what for a patient with infection in order to treat that patient and their needs, rather than to stick to a set of rules that people generally routinely follow because of their training. This speaks to one of the last slides that Professor Lustig showed about AI leading us to personalized care. The reality, this is the beginnings of personalized, individualized care for periprosthetic infection. Now, we know we have all these strategies, but I would say the world has tended to focus on multi-stage revision, whereas I think right now we need to have all these options in our armamentarium and make a focused multidisciplinary decision based on the patient, the organisms, the anatomy, and a shared decision-making model. And that's what we have tried to do. Because ultimately, I think the challenge is to control rather than eradicate the infection. It's pretty difficult to be sure you've eradicated, but we also want to preserve or restore function, and we need to make it affordable, not just for hospitals and healthcare systems, but also for patients. So to that end, we are increasingly using debridement and implant retention. And that may appear controversial because to many of you, this is just something to be used for acute cases. But in reality, the definition of acute is murky, and understanding when an infection actually occurs and when a biofilm starts forming, and even considering that biofilm is not the only way that infection supervenes in a host, is important. So DARE has kind of had a bad name over the years because it's been mixed in, particularly in the North American literature, with incision and drainage and lavage. Whereas actually, if it is correctly applied around well-fixed implants, it's a very, very successful procedure. And our data so far has supported that. It's not something new. These are excerpts from a very old and very good New England Journal of Medicine paper from Zimmerli 20 years ago. For us, a DARE is the same as a revision. It's just we don't change the femoral and acetabular implants. We change the modular parts. We debride, we do a synovectomy, we clean, we irrigate. We do it 2 procedures in one. But DARE is a very, very powerful tool. Very different, as I said already, from I&D, very different from arthroscopic lavage. There is a vogue at the moment at Mayo Clinic for double DARE, and maybe we can discuss that in the discussion. I don't think that's necessarily the future, although, as I'll come back to, local antibiotic delivery is important. The one exception in my hands, if you've got an acute infection around a cementless implant, it's crazy to do anything other than pull it out. Before it's ingrown, take it out and put something else in. One paper to reference for DARE for you. This is the old 2009 Byron paper from Oxford. And the key thing here is 82% success rate. And actually, success was not linked to the time from operation to the time to DARE. In other words, This isn't just for the first 3 or 4 weeks. You can do it later. The 2 caveats here is they're really good infection surgeons, so they did a thorough debridement and they kept the patients on antibiotics for a long time. Another piece of UK data for you that's interesting that shows late DARE here in purple not doing so well, but if you do a late DARE and actually exchange the mobile parts, actually the results get much better. So there is some armamentarium to using DARE sometimes later on. We particularly used this. This is our clinical orthopedics paper from 9 years ago describing partial exchange when you've got big reconstructions that are really difficult or impossible to revise. We've often changed one component rather than 2, and even in unselected patients, including polymicrobials, we had pretty good results. So doing a DARE one side and a single stage on the other side. What about full revision? I think the big argument here is that we are shifting away from what used to be the so-called standard, the gold standard of 2-stage revision, with all its advantages that we recognize, towards single-stage revision more and more because the patients like that better. And in reality, we're starting to understand now that many 2-stage revision patients don't make the second stage or have a high mortality either between stages or after the second stage. So the real key now is to beware just accepting the old data that did not take that into account. Increasingly, I would encourage everyone to start looking at single-stage exchange. You definitely need a good team around you, like I said at the beginning, if you're going to do that. But I think the future of infection treatment will be individualized and will include more patient-specific, more single-stage procedures. We started very gently and very conservatively. Sam Tsiridis wrote this paper with me when we had minimum 5-year results in 2010, but we've continued since then, and we've seen a reflection of these results with better function and very good infection control in the single-stage cases. This is unpublished, updated data. Basically, we're selecting patients for single stage versus 2-stage. We're now much closer to 50% actually than this, but this is over a very long period. But either way, the results of single stage seem to be excellent in those patients who we choose for it. Another caveat, and this is not necessarily something that resonates with everybody. We do 2 procedures in one. So we do the first stage, close, change instruments, change drapes, change equipment, and then come in again for the second stage. And we are increasingly using long antibiotics. Essentially, what you're doing is the same thing as you would do for a 2-stage, but you're doing it all in one day very carefully. There is still an indication for 2-stage. That will vary from center to center. And I think we're all grappling with those cases where we don't have an organism. Our Chinese colleagues have shown good data with single stage without an organism. We're still a little bit nervous, although fortunately our culture negative rate is much lower than we're seeing on the east coast of North America. And there are now some randomized studies. This is the INFORM study. It's actually a very, very good study. It gets beaten up because the outcome was PROMS, but this study actually shows equivalent outcomes at much less cost for single stage exchange compared to 2-stage. So just to bring it all together, I think one of the big things in future is to really consider what success is after our interventions. We really need to look at our outcomes critically, and success is a patient-centered thing. Success is about the patient perspective. It's not how good your x-ray looks or your osteotomy looks. It is all about the outcome for that patient. It's also not just about infection control. It is about function. And so my thesis these days is that we need to have all these tools in our armamentarium, and that there are cases where DARE works. There are many cases where single stage exchange works, and that number is going to increase and increase. And of course, there is still a role for 2-stage. As we get better at local antibiotic delivery, I think the push will be more towards single stage, because we will no longer need cement in the single stages. We'll be able to do the reconstructions we want with local delivery by other means. So thank you to Oliver for putting this together. I will stop sharing my screen and give an opportunity for questions to Eleftherios and Sebastien Lustig for their excellent presentations.
So thank you so much, Fares. This fantastic presentation. So now we have this block of lectures ready for discussion. So there are some questions from the audience, and maybe we will start with the first presentation. Eleftherios, you were talking about a fantastic topic with this femoral revision, but there was a question from Marcis in our audience that asked you how long should be the extended trochanteric osteotomy?
Well, the extended trochanteric osteotomy has got a biomechanical sort of limit, which is 150, 160 millimeters. So actually, the length of the standard primary stem, probably, which is probably what you need to remove a stem from in there. Now, people need to know that usually the stem is actually well fixed at the bottom of it, especially the uncemented stems. This is where it hurts more to remove. So I think an extended trochanteric osteotomy, 150 to 160 millimeters is fine. Now, if you want to remove or to open up the femur and you're planning a revision or second revision stage, then the ETO can be even longer. As I show you, and I particularly put this on removing with an ETO a long Wagner stem, because there are long uncemented stems that need to be removed for various reasons, sometimes for infection as well. So it's a different way. I mean, you need to find a way to fit the new stem in and wrap the bone around. So this is my current understanding of the ETO. It's not limited to the standard teaching, can be even longer.
So wonderful. So there is another question for you in this femoral revision. So in your practice, Eleftherios, what's the rate of modular or non-modular stems? Or what is your indication for a modular stem or a non-modular stem?
Well, it's a straight answer. I try to do in the majority of my cases non-modular stems in our practice. So straight Wagners if you can afford it, or anatomic monolithic Wagners if I can afford it. Now, there's a little tip here. If you need to go long, you may find the anterior cortex in front of you. In this case, you may want to do a little bit of an osteotomy proximally, or to do what we call Paprosky osteotomy. So probably divide the bone a little bit higher up so you can straighten the bone and wrap it around. So straight modular, yeah. Sorry, straight non-modular implant.
Eleftherios, that's really interesting to me. Are non-modular stems cheaper in Greece, or is there another reason? Because the fracture problem with modular stems, has that not been solved now? So is there another reason why you're focused in that direction? Because I'm fascinated by this movement towards these non-modular stems, particularly for lower, you're a high volume surgeon. Some of our audience may not do so many and have the confidence that you have that you're going to get great fixation.
No, it's not a matter of cost. I think it's the fear of not the fracture of the connector. I mean, it exists. I think it's been improved. It is still there, but I think modularity, although it helps, needs a lot of contemplating. So I think for the significant bone loss, a straight Wagner will do the job. I mean, there is a little trick there. You need to go as larger as possible. So people need to hammer it in with a lot of force. It's not just fitting in and slowly going down. You need to hammer it in quite hard, and that produces hoop stresses. Now, my experience, sometimes I hoop stress the bone, and sometimes I experience cracks. Doesn't really matter, I believe, as long as it's stable and you wrap it around with some cable. So cracks do happen, especially in very damaged bone. So no problem as long as there is primary stability. So this is the...
Thank you. There's a question from Sebastien. Sebastien?
Yeah, I just have a question about distal, fixation, distal screw fixation. We still have this in our portfolio, and especially for periprosthetic fracture. Is it gone completely away now, or is it still something we should keep somewhere, just in case we need this extra, distal fixation for rotational issue most of the time?
I think it is expanding. I think now we do have Wagner type with distal fixation with screws. So it's not only the fully HA coated, also Wagner type with a couple of screws down there. There was an issue about subsidence. The Wagner helps because of the fins, so it fits well and stuck. You can stick it down, and then the screws may protect, but I think the fins are doing the job. There are 8 fins around and will provide rotational stability. I don't think, Seb, you should rely on distal screws for rotational stability too much. Unless the deficient bone is too low, you've got very little bone to rely on, so it's a necessity.
Thank you. Let's move to the next presentation, the presentation from Sebastien. So there is a question from Spain, from Madrid, Ana Cruz, from La Paz. So said, in revision strategy 3A Paprosky defects, do you consider modular dual mobility caps in order to add screws in the different position or as cemented in a cage? What do you prefer, Sebastien? What do you recommend?
So my preference would be to try to avoid modularity if I can. So I'd rather go for a cage and a cemented monoblock for all the biomechanical reason I mentioned, especially the jump distance. But we have both, options in the portfolio, and I understand that the secondary fixation for cementless stem is better. But again, I'm more in favor of monoblock if I can. So my go-to would be a cage and a cemented mobility.
So, but in these huge defects, maybe sometimes you need a screw. So you will use this kind of supplement wings in the cups, or what do you use?
Yeah, no, you have different design of cups when you can add some. Yeah, absolutely. You have a proximal flange when you can add screws. You can rely on the tripod fixation. You have multiple design that you can consider also. But yeah, I mean that 2 options. We know that the question was about unstable hip, so we really try to use everything we can to increase the jump distance and favorize the stability.
So there are another couple of questions. One, what is your rate then of dual mobility in revision? 99% of your cases are using dual mobility in revision, or what's your rate?
99.8.
Okay.
No. We revision scenario is a dual mobility for me.
Okay, thank you. And the last question from the audience, Marcin again. In your X-ray protocol in revision, do you use this sitting and standing X-rays of the spine just to assess this hip spine problem usually?
No, I think this is a great question. We use it for primary because we do 3D planning, and we have this virtual movement analysis when we can see if there is some impingement and see how we can leverage positioning of the stem and the cup. So the combined version is very important. I definitely believe tomorrow with the revision robotic assistance we're going to have, that's going to be a key to help us to enhance the way we position both the cup and the stem. So it's coming. For now, I use it for primary, but definitely tomorrow for revision is going to be important. So
interesting your answers. So thank you, Sebastien. And then for the last talk, Fares, thank you so much for replacing Mustafa in this last minute. It was very interesting. So as I understood, so the future is one-stage revision in septic cases? That would be a real thing there?
I generally think the future will be in less invasive, less destructive interventions. And so we will be doing more single stages. And actually, if you have well-fixed ingrown implants, we'll be doing more debridements. And, I think the really exciting work is on new methods of antibiotic delivery, be they short-term catheters. We've had the calcium sulfate beads for a while, but I think there are catheters you can now put around the joint and infiltrate. Some interesting randomized studies using those. So I think we're evolving towards trying to preserve well-fixed implants. But I'll add my caveat from the beginning. I genuinely believe infections should be treated by infection surgeons. The guys on this call, I look at Franco, I look at Seb, these are guys I would trust to treat anybody. And, you've got to be doing a high volume of complex work to be able to make those decisions. The safe option, if everybody's doing it, is to do what we did before. But actually between stages, you're wasting a lot of time, you're wasting a lot of money. So I think we'll do more one stage. Sorry to answer in such a long way, but Stan's got his hand up.
Yeah, there is let's ask our speakers, because there are some of them very interested in the topic. So Franco, what do you think about this question?
It's a matter also of organization. I fully agree with Fares, but in my practice, I'm still on there very often, and the information that he gave us is very important, because still we are sticking to the 4 weeks time for the DARE, and I am very glad to be able to extend my DARE time longer, but I'm still playing on the 2-stage revision rather than a 1-stage revision. Our organization, despite the fact that we do high volume of revision cases, is still on the 2-stage revision. I'm looking for the 1-stage revision, not organized yet, to apply or adopt for 90% of my practice, the 1-stage.
Amazing. Stanislav, you raised your hand. What's your comment about that?
Yes, please. I have a question to Professor Haddad. According to your experience, what do you think? What's the role of alternative methods of treatment, for example, like bacteriophages in management of periprosthetic joint infection?
I think that's a great question, because I think phage therapy is gaining traction in multiple countries. No one's ever been able to do large-scale studies, but actually what I should do is deflect that, because actually on this panel, the person with the greatest experience of phages is Professor Lustig, who kind of runs a group who's using it. So in the UK, we've censored it in Scotland and Northumbria. Mayo has experience. There are increasing companies, but I would go with the Lyon experience, where they've really made it work very, very well. But again, that's uber individualized. Seb, over to you.
Seb, yes, please, Seb, your time.
No, I think I thanks, Fares. I think this is the way we can change the game for infection if it works. Currently, our experience, is for really devastating situation for specific organisms, Staphylococcus aureus, Piosianic. We have some of these. It works very well, but it's extremely expensive. They need to be purified, so the microbiologic part is very important. The surgical part actually is important, but you need to have a very good microbiologist, a very good ID specialist. So that needs a lot of multidisciplinary teamwork to get it to work well. But if we can get the right phages for every different organism, then the future is going to be DARE plus phage and 95% success rate. Completely different game. And I agree with Fares. Well-fixed implants, stay there, we treat the infection, we get this virus, attacking directly the bug, the bacteria. So we will see, but it's very promising, and I hope it's going to work, because that's going to be very good for all our patients.
Amazing. And Eleftherios, any comment about this septic situation?
Well, I like very much Fares' presentation for 2 reasons. Extended the indications for DARE. So we need to dare to DARE and not to leave it behind. Number 2, DARE is a complex procedure. It's not a washout, as the people think it is. So it's a kind of you need to sacrifice a lot of the soft tissues and probably a piece of bone as well if you worry about it. And I also like the concept of 1-stage revision. Although within Europe, we probably prefer in some places, the 2 stages, a matter of this is the way we know it. I think a decent, a properly done 1 stage, in other words, so do the first stage, get everything out, clean up the room, and go back in, change the instrumentation, everything, go out, scrub up again. So it's actually in one event, 2 stages. And I totally agree with Fares. I think this is a step forward to not only to our understanding, but to our practice. And I think I only can summarize the conclusion.
Thank you, guys. Fares, we have no time for more discussion. It will be like 1 hour more discussion about this interesting topic. So we need to move forward for the case presentation from Stanislav. So Fares, can you moderate this fantastic case presentation from Stanislav?
Absolutely. Stanislav, we are over to you. We're in your debt for presenting this case. I think it is remarkable what you continue to do in the circumstances. So we're all delighted to have you here and look forward to seeing your presentation.
Thank you so much, Francis. Thank you. Colleagues, it's my really pleasure and honor to be here with you. And one moment. Yeah. Okay. Today I will be presenting a case from our experience dealing with aseptic loosening of acetabular and femoral components in cementless total hip arthroplasty. To your attention, the patient presented 57 years old, female, who underwent cementless total hip arthroplasty 3 years ago. Due to primary osteoarthritis, she presented to our clinic with a long history of progressive left hip pain, leading to significant walking and standing limitations. Lab tests were within normal limits. Aspiration was performed, and the cultural results were negative, and we effectively ruling out periprosthetic joint infection. And as you can see on this slide, on her X-ray, we can observe position of acetabular cup and femoral stand, and you can see clear signs of loosening. And my first question concerns preoperative planning. Dear colleagues, how would you approach further imaging in this scenario? Do you think CT scans alone are enough for planning of revision, or should we integrate additional techniques? Please choose your option, one or two.
Please vote.
Can we open the voting, Oliver? Because at the moment I don't think it's working.
Yeah, it's not working for the panelists. Sorry, Fares, we cannot vote.
That's okay. I don't mind not voting.
Okay. Okay. Great. 62% voted for the second option, CT scan and something else. Great. Let's move further. CT provided for us a detailed assessment of the bone implant interface and overall bone quality, and we can see clearly signs of loosening of acetabular femoral components that are well visualized on CT scan, and also we performed to this patient 3D reconstruction with 3D model plus sedimentation. Using 3D modeling, we create a highly accurate digital model of the affected hip, enabling better visualization of anatomical challenges. Moreover, this method allowed us to see and assess the extent of the defects much more accurately. Next, we performed plastic model, physical model was produced, which allowed us to stimulate implant placement and to refine our surgical approach. And my second question concerns acetabular implant choice. You can see 5 options. First, cup with augments, anti-protrusor cage. Second, cup cage. Third, impaction grafting with cemented cup. And the last one, customized 3D printed implant. Please choose, vote for one of the 5 options. Okay. What we have, 58% anti-protrusor cage with allografts, and 17% cup with augments, 17% impaction grafting, 8% custom-made 3D printed implant. Great. And move further. And the last question about femoral implant choice, 3 options. In this case, modular revision stem, monoblock stem, or cemented revision stem. Please vote. Okay. What we have, 50% chosen monoblock revision stems, 43 modular, and 7% cemented stem. Okay. And our results, in this case, we performed revision. We use customized 3D printed highly porous titanium tri-flange component. We use allografts for reconstruct part of the defect, and for the femoral channel we use monoblock Wagner revision stem, and you can see early follow-up results in 1 year after surgery with restoration of hip rotation center and length quality. Thank you very much for your attention, and we're happy to answer the question.
Dan, that's a great case. How do you manage acetabular version in these cases? Because often the cage will tend to pull you into retroversion. Does the tri-flange build that in, or do you have to cement the poly into it?
Yes. We use cemented cup, and it's easy in this case to put it in correct place.
Very good. And did you aspirate this hip, or did you work out the cause for failure? Was it over-reamed, or what happened?
Sorry?
Was it, how soon after surgery? I missed it at the beginning. How soon after surgery did the failure happen? How soon after the index procedure?
It's happened 3 years after primary. After primary, it was not our case, and we performed 2 times punction of the joint. We ruled out infection and decided to perform a revision.
Excellent. Any comments from Franco or Eleftherios on this in terms of
thank you, Fares. Despite the fact that I will be defending the customized implant in my talk, I wouldn't use the customized implant in this specific case, because a bone impassion grafting with a cup cage, in my hands, I think it would be more than enough. Or even the solution with bone impassion grafting and cemented cup, in good hands, it works very well as well. So I do not defend the customization for this specific case. Sorry, Stan.
you can defend it in 5 minutes.
Okay.
I mean, I was intrigued by using a customized cup with bone graft, whereas most customized cups we get try and fit to the bone stand. Was there a particular reason for that? I mean, I reckon you've done it beautifully in terms of restoring center of rotation, but typically when we customize onto the bony envelope.
Yeah, but we should think about a future revision, and I believe that we restore part of the bone of the socket.
No. Well, it shows us, shows us what a master surgeon you are, because you've managed to bone graft and still get the custom cup to fit, which is tremendous work. Because that's, often it's a little bit of playing to get those customs to fit properly. Eleftherios, final message on this from you before we hand back to Oliver for the debate.
I think Franco has a point. 3D printed implants are for the extremes. However, that could be considered an extreme because there was a kind of a protrusion defect. So a combination of impaction grafting properly done with another construct where there was a jumbo socket with a cage, cup cage, or in your case, a 3D printed implant will do the job. Good fixation with several screws is the key. And as we say, the anchor screws to the pubic rami is important, not only the top screws, also the bottom screws. Otherwise, the socket may flip. So I think that's the point.
Wise words. Great case, Stan. Thank you so much. I'm going to pass you back to Oliver. I'm hoping Matt Wilson has resurfaced from his big case and that we're ready for the debate.
Thank you, Fares. Let's continue then with our agenda. And I think Matt Wilson has joined us. Hello, Matt. Nice to see you.
Good evening.
Good evening. Good evening. I promise that we will not talk about football today, about Madrid and Liverpool. So let's talk about science, right? Okay. Then we are going to start the Crossfire, and we have two speakers that are great experts about different approaches for the same problem. So we are talking about these acetabular defects, and Franco Benazzo will talk about these customized implants, and Matt Wilson will talk about this impact of grafting. So Franco, please.
Thank you. Can you see my slides?
No, you have to share your screen first.
I will do immediately.
Yep.
Now?
Yes, please, go ahead.
Okay, thank you for the invitation. And let's go back. Let's start from the first slide. Well, I start from the second one, and these are my disclosure, and I have some relevant conflict of interest with a novice because of my work with the customization of the implant with them. So thank you also for the title, the heavy metal solution. So that means customization. When do I think to customize? Well, I tried to give an answer to this with this chapter in this book published 2 years ago, when the bone is not enough. So the role of custom-made implants in camp revision surgery has been discussed thoroughly in this chapter. And for me, it's a matter of classification because we do have issues where allograft and bone impactional grafting can address the problem, but other cases where it doesn't. And if we use this classification, you see that type 4 is definitely only for customization of the implant. We are working on that, and we are working on this our own classification, and we are validating the classification. So we are looking at the missing bone, where and how large is the defect, and also to the remaining bone, so where it is possible to graft. Desirably, we should have also information on the quality of bone, which is always a guess. Planning is absolutely important, and planning comes together with this the classification of the defect and the classification of the remaining bone. I will bring you some examples. So we have this area we have called alpha, and we have divided in alpha 1 and alpha 2 when we do have a pelvic discontinuity. And this is an example of alpha 2 pelvic discontinuity, where for me it was very difficult, considering also the failure of the previous cap cage, to consider bone allograft and off-the-shelf caps to reconstruct the center of rotation and to reconstruct the missing bone. So we went to this solution. I like very much in the customization of the implant of using what I call the iliac stem or McMean-like stem. And I only show you the CT scan after surgery that we performed to see how beautiful the stem was inside the iliac wing. The beta area, when we do have an anterior column extension of the bone missing, or the missing bone over there, and this is an example, and the solution has been this planning and this project. I will comment on the importance of discussing the project with the engineers. And that's final X-rays. We are not fully satisfying, so somehow disappointing, because I've not been able to put the 2 distal screws. So far, what has been prevented by Eleftherios before, so the flip over of the cap, has not happened yet. So the patient is still working on this construct. The gamma area is when we do have a posterior column extension. And this is an example This was a truck driver, by the way, coming from Ukraine, and the acetabular fracture, he has no treatment. So he was referred to me in this situation of failed cup and dislocating hip. And that was a CT scan and 3D reconstruction to plan the construct. And that was what we had after 5 years, with a full integration of the cup. The gamma 2, when we do have an extension over the greater sciatic notch or the failure and or the bone lysis, and this is the reconstruction, this is a planning, and this is solution. Again, that's is a situation of the where the bone impaction grafting in my hands could not work at all. And when we have a destruction of the pelvis, I'm not talking about tumors. I'm really talking only about failure of a primary implant. That was the situation. And by the way, Oliver, I have operated this lady in Spain, in Valencia, and that was a construct, and that was the results after the surgery, where with the planning, I also had to consider the impossibility to remove this very long cemented stem. So just to going back to the my question, when do I think to customize? Well, to my opinion, when we have very large, sorry for this term as overclassified bone defects, and we do need a classification, or in case of multiple revision, or where we think that in our hands, off-the-shelf implants are not suitable to guarantee on the remaining bone stable, durable fixation, and together with the reconstruction of the offset and center of rotation. And when we think that we have, considering the quality of the bone, the high risk of failure of a standard solution. So these are my principles where to decide to customize. And the need of a classification is important for me because with talking the same language, speaking the same language, we can have an improved collaboration with the company and with the engineers. And we can start to think of standardize the custom construct like an off-the-shelf product. That will reduce the liability, which for the moment in these customized implants are entirely on the shoulders of the surgeon. And to make the custom design and production faster, reducing the time between the project and the surgery, and also from the economical point of view could be very interesting. So in conclusion, my hands, to my opinion, and this is another paper we published, is the heavy metal solution are a reliable option to reconstruct the anatomy and function. Planning is a key point of the procedure, just keeping in mind that this is one-step surgery. And so let me go to YouTube and think that heavy metal will be really a solution. Thank you.
Thank you, Franco. It's amazing presentation. So remember to the attendees that you have to vote the winner of the Crossfire at the end, and the winner will receive in our next European Society meeting in Thessaloniki in October. So there is a surprise of the award for the winner. So I will let you know later on. But now we have the option for Matt Wilson to present this another option for the acetabular defects, this impaction grafting. So Matt, the podium is yours.
Thank you very much. And thank you for the invitation to talk. Yeah, so we'll talk about why I might prefer bone impaction grafting. So we've got disclosures related to research support for our institute. So there's no doubt that we all love a bit of heavy metal in our operating theatres, but there perhaps is a time and a place for it, and maybe something a little bit more classic, a little bit more elegant is required, and that would be, in my hands, bone graft, either impaction bone grafting, as you can see, or bone blocks. So our aimed at revision surgery are obviously to restore anatomy, give a stable hip that lasts a long time, and ideally, perhaps in the younger patient, restore bone stock, and obviously with the use of bone graft. It's not something that's suitable for everyone, but there's no doubt that it's preferable for some. You clearly need the right environment, and by that I mean bleeding bone. And I think the same is probably true if you're using the custom implants as you've just seen. I've said no infection in brackets because I think that's a relative contraindication. We've published on using impaction bone grafting in infection, and as have many others with good success. It's actually, certainly impaction bone grafting is quite a good carrier for antibiotics as well. Slightly counterintuitive because obviously it's dead bone, generally speaking. You do need the right equipment, you obviously need the right technique, and you need the right graft. And when we talk about graft, there's various types, obviously. Autograft seems odd to use in revisions, but we have, in a patient who needs a revision surgery, used, but also has arthritis on the other side. We've done their arthritic hip first, and we've stored their femoral head, and then used that when it comes to revision surgery. And there are other groups that have stored it intra-abdominally or in and around the iliac crest for later use. So these are all possibilities. But allograft would be the main type, stored in a bone bank. And I think that's one of the major downfalls, is that you do need a bone bank. And certainly in the UK, having a bone bank comes with a lot of paperwork, a lot of administration. But I think if you have one, then you will use it, and you'll be surprised how much you use it. I think those units that never use bone graft have just never had a bone bank. They haven't had it as an option A. You can use bone block, obviously fairly structural allograft bone blocks, or it can be milled bone, which is perhaps slightly more biological. So impaction bone grafting obviously originated really in the Netherlands. Robin Ling and Graham Gee went to the Netherlands and brought that back to Exeter, and obviously developed the femoral side as well. And we've published on our results in without cage reconstruction in a fairly complex subset of patients. I mean, not amazing results, but I think there's many patients in here who probably would have porous metal or custom implants now. But certainly for many cases, and cavitary defects in particular, I think that there's no doubt that impaction bone grafting or bone grafting of some sort is the gold standard. And here you can see a nice contained defect, good sort of containment of bone all the way around, but a very large voluminous defect with very thin walls. And yes, you could fill that with metal, but these are absolutely ideal cases for impaction grafting. So the bone is milled, antibiotic added to it, it impacted in layers until you get a very firm, hard impaction at the end. And you can reconstruct walls as well, which is something you can't do. If you're putting uncemented implants in, generally speaking, you're taking away bone. You are not adding it in that situation. And then really you have simply a primary operation. So you have a reconstructed acetabulum, you insert cement, pressurize, and insert primary components. And what you're ending up with really is turning back the clock. So impaction grafting, quite a thick layer of graft in this case, as you can see, same on the femoral side. But trying to make your revisions look like a primary, I think, is key. What about uncontained defects? Well, you can see a cemented metal-backed cup here that's failed in zone 1 with a loss of bone stock. So that's an uncontained defect. And we've used perhaps a hybrid construct, so a combination of a little bit of heavy metal, perhaps porous metal as rather than a mesh to close off that defect, and then impaction grafting underneath that. And we've published on that as well, as have others, with promising results in the medium term. And that's the sort of some of the results that you'd get with that. Here you can see a case that has had some porous metal and it's failed and disappeared inside the pelvis. And you could do the same thing again, but perhaps that's foolish. So this case had impaction grafting, but due to the extensive nature of the medialization, this graft was protected with a cage. And down the line, I think there's not resorption. There's perhaps some evidence of incorporation, and that for us is a fairly nice reconstruction. Here's another one, a metal-backed cup, an uncemented, well-fixed cup with some lysis behind the cup, as you can see here. Now, you could take out that shell and curette out and fill the defect with metal, but actually that is like a support ring. It's well fixed. So in that case, we would find a window, and often you can get round in the anterior column, and we would pack bone graft into that quite extensive defect. And I think you can see here down the line, good incorporation of that bone stock over time. So these are all options just to try and turn back the clock and not take yourself down a road that you don't want to go down. Here's another case of a furlong uncemented cup with a screwing cup, lots of medialization, but perhaps looks like a contained defect. There's a superlateral wall, you can see a posterior wall, but there was an anterior defect. So this wasn't ideal for impaction bone grafting, but this is really a nice shape for a block autograft. So a block autograft was shaped, the cortical bone was removed from the outside and placed inside an uncemented shell on the top. And the nice thing is you can get the screws up through the graft into the host bone. You're not having to work screws around lots of metal augments deep inside there. Here's another case, a couple of ring prostheses that have disappeared inside the pelvis. We tackled one side first. This is impaction grafting, a nice contained defect. The other side was a little bit more extensive and required protection with a cage. So pretty horrible defects, but I think about 7 years down the line, you can convince yourself that there is some incorporation of that bone. And again, trying to just turn back the clock a bit for these patients. So I think bone graft is the perfect plan A. I think there are potential downsides. Obviously, you need a bone bank. I think the infection risks can be mitigated, but I think there's also the risk that it's a bit of a lost art. I think the benefits are it has the ability to restore bone stock, turn back the clock. I think it's very easy to work with, and it's relatively cheap compared to custom implants, certainly, and it's certainly effective. And if it doesn't work, you can always move on to your plans B, C, and D. And I truly think if you're a revision hip surgeon, then I think you absolutely should have impaction bone grafting or the use of bone graft in your armamentarium as an arrow in your quiver. Thank you very much.
Thank you so much, Matt. Amazing presentation as well. So happy to manage this discussion between Franco and Matt. So I think it's so interesting. So I mean, in summary, we are facing with the heavy metal versus classic music. That's what you mentioned, Matt. So any limitation, Matt, of your technique? So where do you think is a contraindication actually?
Yeah, I think it's a bit like femoral impaction graft. I mean, developed at the time because there were no good femoral revision implants, and done very infrequently now because there are very good femoral revision implants. And the same on the acetabular side. I think very extensive acetabular defects, very large uncontained defects. I think we've shown, we used to do impaction grafting on them because it was all we had, but I think we've shown that that doesn't work very well now. I think if you can close the defect with an augment in a small superlateral defect like I showed, then I think it's still a very good option. But I think for contained defects, it's certainly the gold standard. I think the large uncontained defects, then I think the stuff that we heard about earlier is from Francesco, I think is absolutely has been a game changer, and certainly in terms of custom implants for certain very big posterior wall lacking cases, I think is probably the future.
So Franco, do you want to say something, because I can't see your hand raised?
Yes, I want to say that in no one of the cases presented by Matthew, I would use a heavy metal solution. I fully agree with him. So it's a difficult battle that we had, because it's a matter of classification, it's a matter of defects. And uncontained defects that they show in my hands, or I think even in the hands of Matthew, would have been impossible to reconstruct with bone impaction grafting, even with the use of the mesh that he showed. So in no one of the cases he presented, I would have used a heavy metal solution. And I like to use bone impaction grafting exactly in the way he showed. I've been in Exeter many times. I learned how to use a bone impaction grafting. We do have a bone bank, so perfectly agree with him. But in the cases I had presented, no way of using bone impaction grafting and off-the-shelf solution. We do need, in those cases, another type of solution that I presented.
Yeah, Franco, but we need to controversy. I mean, this is a crossfire. Don't be so polite.
Crossfire, but we have been talking about two different animals. I mean, it's a crossfire on two different animals. It's like comparing apple and oranges. I think that, yes.
Francesco is extremely experienced surgeons, but I think the worry is, certainly in the UK, is the use of custom implants is people are defaulting to it now. They're going through the roof and they're extremely expensive. And I think people are just choosing that as a plan A rather than thinking about maybe simpler and certainly more cost-effective options that are just as, if not more, effective. I think that's the big challenge we have in UK at the moment. We have a limited budget for our health service, and I think a lot of it is being spent on these large, porous custom implants, and that's something that needs to be addressed and contained.
I fully agree with you, but in our hands, in Italy now, the mesh, the stainless steel mesh that you showed, they are not imported anymore by Stryker. So I am surviving with pieces of this metal that I had from previous surgeries, and so that solution, which is not as expensive as the first one, with a good indication, is not available anymore in Italy. And bone impaction grafting is not loved by the Italian surgeons. The lost art of what you showed is really lost art.
Yeah. There are other meshes available. I'll ask Oliver if I'm allowed to say the company that makes them, but they're based in the Netherlands. They make actually much better meshes than the meshes we have historically used. But I think the same reason that companies are removing these meshes, certainly from the UK, is with this European regulation or UK MDR, which is the equivalent. And the same is happening with cages. I think we've all showed some cages in our cases today, and they are a really useful adjunct, but I don't think they make the companies any money. So they are very happy to have an excuse to stop supplying cages. And so cages are disappearing off the shelf, left, right, and center. And we have very limited choice and stock supply of cages as well. And I think they're an essential tool, again, for revision hip surgeons.
Yeah, this was the question from Anna Cruz about these meshes. Maybe you haven't now give the correct answer, but there is a question from Sebastien. Seb?
Yeah, just a question about custom implants, and I think the comment about the cost is very important, because I know that in Argentina, for instance, they have pretty low cost custom implant for revision, and that for them that's option number one, and it's easier for them to get access to that than to get access actually to allograft. So I think for us in Europe, it's going in this direction. And I know in South America, it's going in the same direction for different reasons. So it's interesting to understand the constraint, and the cost is one of them for sure. And the technique, I agree. It's when you see the beautiful video and the beautiful X-ray, post-op X-rays, you understand that we need to learn that, and the young surgeon, they need to learn how to do this, because the technique is very important for bone impaction grafting.
Fully agree.
Yeah.
Matt, what are you doing for your discontinuities?
For those, we have done impaction grafting for those. I think it depends how extensive the discontinuity is. Again, I think if you had a contained defect, you could get stable and plate with a posterior column plate and then impaction graft, then we would do that still. But I think it just comes down to stability, because if you haven't got a stable graft, and that's why the big 3B defects failed, because you just couldn't get enough stability with those stainless steel meshes, and therefore, like your non-unions in fracture surgery, the graft turned to fibrous tissue and they failed. And I think that's the big risk with discontinuity. So we would plate the posterior column and use uncemented implants, porous 3D custom made for the right defect with no posterior wall, but generally speaking, just wedges and cages, as I suspect most people would nowadays.
Or you can overcome the problem with a stem, with an iliac stem, with I call Ming-like stem cap, customized, of course.
So yeah, remember that people will vote you, both of you. So one last question. Well, there's a question from Eleftherios. Eleftherios first.
Yeah, it's not a question. It's a wonderful point from Francesco made, that the cone type. This is a very important structure. This is central peg, that it is usually 7. It's quite thick. It's not actually 4.5. It's over 7 millimeter, and it's like a peg. You don't screw it in. You actually hammer it in. And this is a very important, because it goes straight to the SI joint where the bone is very strong. This is where the cone goes. And this is because the surgeon has the ability to discuss with the manufacturer how to fix it on, and it's not about the shape, it's about the anchoring devices. So unless you do something very thick, strong, and long to go to the SI joint, the rest of the screws may not hold. So I think it was a wonderful representation of this. People should never forget this very big peg to the SI joint.
Thank you. So one question for Franco and one question for Matthew. I mean, Francesco, do you think in the future there will be like in the orthopedic departments this kind of printing machines in metal, and the cost will go down and we can use this type of implants for a very low cost? What do you think about these new the machines? Yeah.
The cost will go down if we standardize the solution with the proper classification. So if we arrive to have enough cases, this is the classification, this is the bone lysis, bone loss, and this is a good solution that we have found with the good number of cases. So we can standardize the solution and reducing the number of hours spent by the engineers in planning and finding the different solution, and that will reduce the cost. Not having the 3D printer in the hospital. I do have my 3D printer, but only for modeling and not for preparing, because that would be impossible according to the rules that we have in Europe. Okay.
Matt, one question about the graft. I mean, there are some limitation in many countries about the graft, as we have some people mentioned here. What do you think about if you mix with any other materials like calcium sulfate or whatever? Do you think it's a good idea, or the structure and the support of the new mix parts will not work very nicely?
No, I think there's good evidence that works. There's various different types, some work better than others, but there's good evidence for artificial bone substitutes working. And again, it's just about having a bleeding bone, no infection and stability.
Okay, thank you. Any other comment from our speakers? Any comment? Maybe Eleftherios, do you have your hand raised? Or
very quick one. Dealing with discontinuity or suspected discontinuity, whatever, sometimes it's a very broad area and you don't know really what is bone and what is fibrous tissue. Sometimes it's not necessary to try to find the anterior posterior wall. You can play it actually from inside out, especially the anterior wall or probably the roof in the anterior wall, which is deficient. So a little trick with a 1/3 tubular plate can hold it together. So plating from inside, not from outside.
Good concept. So I'm sorry, gentlemen. I mean, it's time to vote, both of you in the Crossfire. I know you are nervous. Who is going to win the fantastic prize that the European Society will give you? Probably, I don't know, something important, but these are the options. Please vote. The first speaker would choose heavy metal or would prefer bone or classic music. Please vote. So nervous, right?
I can't vote, Oliver.
No.
We can't vote ourselves.
We cannot vote. We cannot vote.
You're blocked.
It can be joint winners if there are even number of people. Oh, it's 50.
My God. Look at the numbers.
I'm sorry about that.
Matt, you won. You have a fantastic presentation. So congrats.
I have the privilege to chair the next conference. I think two different sort of animals, two different prizes for both of them.
Okay. So, guys, we are out of time. So I will just say thank you to all the speakers, and I will do like a wrap up of the webinar. So remember that at the beginning we have talked about this aseptic loosening from Eleftherios that proposed these non-modular stems, distal fixation, and extended trochanterial osteotomy as one of the standard in revision. Sebastien had mentioned that 99.8% of the cases in the revision should be dual mobility. Thank you for the summary. And Fares mentioned the future of this one stage or maybe less aggressive approach to these infection cases, and with very nice results. In the case, Stan show a fantastic combine of grafting and custom-made implant. Thank you, Stan. And in this debate, Again, thank you, Benazzo, for this heavy metal proposal, and also Matt, you won the prize with this classic music for impaction grafting. So, Fares, any other comment to wrap up?
No, I think great set of presentations. Revision hip is a massive topic, but I think we've covered it extremely well this evening. We'll look forward to receiving feedback as to what we missed or what we could have done better, but also what we should include next year and the year after. So thanks to the audience for joining. And Oliver, thank you for doing a fantastic job on behalf of the European Hip Society, setting up these webinars.
So thank you to all of you for this fantastic time. I hope to see you soon in another webinar, or maybe in October in Thessaloniki. Bye, guys.
Thank you. Bye.
Thank you very much, everybody. Bye.
Bye-bye.
Recording stopped.
Awesome. Well done, guys.